Well, welcome back and thank you so much for joining us. Again, this is day 2 of the STI intensive course. And this morning we have Caroline Carnevale. She is the clinical lead for HIV prevention services and a nurse practitioner with the Comprehensive Health Program at New York Presbyterian Hospital, Columbia University Medical Center. She joined the New York City PTC as core faculty in 2020. And today she will be presenting on PrEP. We do want to go back though. There was a question from the DoxyPEP presentation. We do want to just address that. And the question was, could you please clarify what we should look for in breakthrough syphilis in a client taking DoxyPEP?
Great question. So I think one of the things that I would start out with is doing a comprehensive physical exam, looking for chancres and looking for secondary syphilis. So if you are worried about the patient having breakthrough syphilis while on DoxyPEP, I think the first step, and other than continuing testing, is to do a comprehensive physical exam to look for symptoms of primary and secondary syphilis. All right, we're gonna get started. Feel free again to use the chat or QA. What are we using for
Q&A.
the Q&A for any questions you have? And I'm really excited to be with you guys today. You already heard all about me, so I don't need to do that, but I have no disclosures. Okay, so we're going to go through some HIV epidemiology just to see where we are as a region and a country as far as HIV, the HIV epidemic. We're going to go through PrEP options counseling, which is how we are framing education around PrEP these days as a way of encouraging patient choice. We're going to talk about on the oral daily regimens, on-demand cabotegravir injectable, and lenacapavir injectable. And we can talk a little bit about our sexual health clinic. All right. So in the United States, as of 2023, there were over 1 million people living with HIV. This most certainly is an undercount. It is estimated about 15% of people living with HIV don't know their status. And that's roughly 1 in 8 people are walking around undiagnosed, not linked to care, not in treatment. So I know a lot of folks who come to the STI intensive work with adolescents. I just want to make a plug here that if you are an adolescent provider, this is a unique opportunity for you to start talking about PrEP and talking about HIV with your patients. So when you look at this map, you'll see that New York is still one of the darkest states, indicating that our prevalence is pretty high. Also, along the south as well. So this is a really good opportunity if you live in any of these regions or states to start thinking about how you can address HIV prevention in your practice. So as far as newly diagnosed, so in 2023 there were about 40,000 people who were newly diagnosed with HIV. So this just means despite the advances in treatment and prevention, we are unfortunately not able to suppress enough of the infections. HIV does not discriminate by age, race, or orientation, and it does not affect everyone equally. So the next slide I will show you is the populations that are bearing the greatest burden. So when you see this data, I want you to think about who's sitting in your waiting room and who would benefit from HIV prevention education. Spoiler, it's everyone, but there are certain populations that we should be thinking about HIV prevention more so. So ages 25 to 34 have the highest number of HIV diagnoses and also the highest rate in 2023. Ages 13 to 24 have 18% of the new diagnoses, and 44% of this population does not know their status. Young Black and African American MSM ages 13 to 24 represent 47% of all the MSM diagnosed in that group. This is a serious crisis of equity, not just epidemiology. So this is like a striking disconnect. Young people are diagnosed at the highest rate, but they're least likely to start on PrEP. We have a tool, we have many tools now, but the uptake's not there. So I just want you to think about why that might be. In part, it's because no one's talking to them about it, right? Not at the right time, not in the right setting, not at the right level of trust. So I would like to just emphasize that the first time you see a young person in your clinic is really amazing opportunity to start this conversation in a way that is not stigmatizing and also meets them where they're at. So to identify gaps in PrEP provision, this is from an amazing website which anyone can view. It's called AIDSview. They developed a PrEP to need ratio, which compares the number of people using PrEP in a region to the number of people newly diagnosed. So, and develop a ratio. So you can drill down to even community level. So if you want to look at the neighborhood you're practicing in, you can see what the PrEP to need ratio is. I think this is really helpful in just having a better grasp over what regions maybe need more emphasis on deciding who we're going to educate to, maybe more targeted resources, etc. So, for example, in Maine, 40 persons using PrEP for every 1 person acquiring a new HIV infection. In California, it's 16.2 persons using PrEP for every 1 person acquiring an HIV infection. And Louisiana is 7. So lower means that we're not meeting the population. In New York State, we're going to talk about it in a little bit, but just to kind of look, you can also in this website drill down demographics. So women, younger populations, and Black and Latinx patients are the groups with the greatest gap between need and use. Ages 13 to 24 represent 18.3% of the new diagnoses, but only 11% of the users, like we said previously. This gap is not a coincidence. This reflects who's being offered PrEP and who is not being offered PrEP. So your patients in this age range are unlikely to hear about PrEP from a provider. So now this could be you talking to them about PrEP. This is a significant opportunity to be able to meet patients where they're at before they are experiencing significant risk. In New York and specifically, which I know a lot of us are in 2024, there were nearly 1,800 new diagnoses in New York City, which is a 5.4% increase from 2023. This is going in the wrong direction. We want that number to be going down. Unfortunately, 44% of newly infected individuals identified as Black, 41% as Latinx, and 66% were ages 20 to 39. Approximately 5,500 people in New York City are living undiagnosed right now. Specifically in the neighborhood that we practice in, you can see the more deep purple color, and the neighborhoods that other people that we're looking a lot at, Brooklyn, Northern Manhattan, and the South Bronx as areas that could definitely be providing more PrEP education. So this is from, you can also access this website. It's at the ETE, New York State ETE website, to show what we're looking like as far as PrEP uptake. The number is definitely going up. There's more people on PrEP, which is fantastic. Unfortunately, it is, there is some disparities in the uptake of PrEP, which I'm going to show you in a second. So, engaging patients in PrEP education before 25 can significantly prevent thousands of national infections. This is specifically for youth. As we said before, youth have the highest unmet need for PrEP, the PrEP to need ratio. So the opportunity here is to look at the different age groups that we're taking care of and where we could do better. And specifically, adolescent and pediatric providers are uniquely positioned to make the most difference here as far as talking to folks when they're younger. Okay, so in my opinion, there's 3 things that need to shift. How we approach HIV testing, an emphasis on universal education or universal HIV testing, and emphasizing opt-out testing specifically for adolescents who may not be entirely vocal about their sexual experiences. We need to change how we conduct sexual behavior assessments. We need to use affirming, non-judgmental, comprehensive language that does not assume heterosexuality or abstinence. And we need to change how and when we educate patients on HIV prevention options, including PrEP, condoms, and treatment as prevention. This is not about adding more things to your clinic day. It's about reframing how we talk about these things in your clinic day. So opening the door to talking about PrEP. Have you heard about PrEP? It's a great way to completely change a patient's life in front of you. Just that simple question. So I'm just a little plug for the status neutral model. Every person gets an HIV test who walks in the door, and depending on that test is where the care will continue. So if that person is positive, engaged in treatment. If that person is negative, engaged in prevention. Let's meet Sam. Sam is a 18-year-old African-American male. He had to leave his home in the Midwest after disclosing to his family that he was gay due to the abuse that ensued. He came to New York in 2025, never been on PrEP previously, heard about it from a friend, and was interested in learning more. So he met with our team. So we have a coordinator, a social worker in our status neutral clinic, and we began PrEP options counseling. So when I say sex positive care, what do I mean? Sex positive care, this idea is celebrating sexuality as a neutral, healthy part of life. It strives for ideal sexual outcomes, not just preventing negative ones. It acknowledges diverse risks without reinforcing shame, taboo, or fear. In a clinical practice, it's changing the way we're talking about sex as using more of a goals framework or the goals framework. So in a clinical practice, asking about sexual pleasure, goals, not just risk behaviors. Providing non-judgmental, inclusive STI and HIV counseling, and offering PrEP and harm reduction tools as health optimization. So why does this matter for equity? There's been a plethora of data showing that Black MSM have reported discomfort disclosing sexual histories to their primary care providers due to stigma. And since PrEP's introduction, medicine as a whole, I think we'll all agree, has struggled to engagement of color in prevention modalities. A sex-positive, goals-oriented approach might be the key to engaging this historically underserved population and historically underserved populations. So this is some examples from our friends at the DOH of their sex-positive messaging, which we love. This was last summer. This was, I'm dating myself, 3 years ago. But this idea of celebrating sexuality in addition to also celebrating prevention is those two together are a happy pair. So this is the goals framework for sexual history taking. I would recommend all providers take the training. It's available free to you online. But one of the things it emphasizes is universal screening for PrEP education and HIV and STI testing, emphasizing benefits rather than risks, positive interactions with a healthcare provider to promote engagement in prevention and care. So patients actually really want to talk to their provider about their sex life. They just need a door to be able to do that. And one of those doors could just be you asking, how is your sex life? All right, back to Sam. So what did a comprehensive status neutral sex positive care look like for Sam? So we started with the goals framework, which I just talked about. So Sam talks about his 20 plus partners, including cis male partners per month. He sometimes exchanges sex for money. He has anal and oral sex, and he recently had gonorrhea and syphilis. He had a rapid HIV test that day in our clinic. So if you're thinking about the status neutral framework, we're now going down the negative side of the framework. We did an SDOH screen. He had a positive mental health screen. He has food insecurity. The biggest barrier for Sam was he cannot use his parents' insurance, although he remains on his insurance because he's not speaking to his parents. So that's a barrier, as everyone who provides this care knows. It's pretty hard to get somebody PrEP if they're insured but can't use their insurance. PrEP options counseling then took place. Whole question. All right, what do I do? Anything? Nothing? Oh, she wants. Okay, so what's the biggest barrier you face when talking to your patients about PrEP? Time during the visit, my own comfort discussing sexual history, patient stigma or hesitancy, insurance costs or concerns, or lack of familiarity with newer options. Thank you guys for responding. I'm going to try to get to 60%. Let's see. Almost there. Okay, maybe 55. Okay, fine. All right, this is what we got. Most people, surprise, surprise, America. 62% of people are insurance or cost concerns. Lack of familiarity with newer options. I'm super excited to talk to you about those today. So maybe we can make that number go down. Time during visits, I hear you. Patient stigma or hesitancy talking about it. I also hear you. Hopefully some of these, the PrEP options counseling we're gonna go through, will give you guys some ideas about how to bring both of those numbers down. Oh, one more. Which PrEP modality are you least comfortable discussing with your patients right now? Daily oral PrEP, 211, cabotegravir, or injectable lenacapavir? Cabotegravir, rather. Oh, do I stop? Okay. Okay, there it is. Daily oral, 211, cabotegravir, len. Two and one for the win? I'm so excited. That's my favorite. $55 again, same people. Stopping and poll. Share results. Okay, so 211 for the winner, which is great because I love talking about 211. We're going to talk about cab and we're going to talk about len. I'm glad more people are not, there's not a lot of people uncomfortable with talking about daily oral. We're going to talk about that too. Okay. Stop sharing. Boop. All right, PrEP options counseling. So who should receive information about PrEP during their medical visit? Spoiler, everyone should. But the recommendation from the CDC is all sexually active adults and adolescent patients should receive information about PrEP. If, for the folks who don't have time during their clinic visit, completely understand. I'm going to show you links to some flyers that you can put around that could help patients look through it while they're waiting, look through it while they're sitting in the exam room, whatever it is. But in any way that you could put information about PrEP in your clinical site, that is education. Patients can see that. They will look at it when they're sitting there not looking at their phones. Okay, PrEP indications for sexually active persons. So this is the algorithm from the CDC. While I feel like everyone should be educated, I just want to draw your attention to the bottom green areas, green boxes in all of this. So basically all roads lead to prescribing PrEP or discuss PrEP, prescribe if requested. So no matter what your patient is doing, you could go through all these questions, that's fine. But no matter what your patient's doing, you're prescribing PrEP or you're discussing PrEP and prescribing if requested. So regardless of STIs, regardless of how many partners, regardless of if they haven't had anal sex in the last 6 months, you're still discussing PrEP and prescribing if requested. This makes room for folks who don't feel comfortable talking to the provider about their sex life. This makes room for folks who are yet to have sex but want to have sex soon and are trying to prepare for that. There's a lot of things that can be taken away from this algorithm, but I just want to emphasize that the CDC is recommending that we're prescribing or discussing PrEP and prescribing if requested. So I should talk to everyone about PrEP? Yes, and this is how you can do it. So this is PrEP options counseling. There's a lot of evidence for those of you from the more reproductive health end, you know options counseling from birth control methods. This has been a well-studied methodology for educating folks on prevention and methods that best suit them. So options counseling, there's a lot of things it does, but it increases retention and satisfaction in the choice that the patient is working on with their provider. It decreases stigma if you present all the choices and all the options. There's nothing that you're targeting. It increases patient satisfaction with the clinic experience and with the provider. So we start with an open-ended discussion about sexual health goals, like I mentioned. And then so this down here is the website, hivblueprint.org. You have to have Dropbox to access it, FYI, but you don't have to sign up and register on the website. You can download this and other documents they have. But So for potential and current PrEP users, they have the right, and it is beneficial to them to understand the pros and cons of each HIV prevention option. So side effects, both short and long term, potential drug interactions, cost, both financial for the medication that you're purchasing, and time spent having to come to the clinic, time spent traveling, logistics, so testing, how often you're expected to come in for testing, in the visit schedule, and the implications for stopping and switching methods. So some are more restrictive in that way, some are not. If you have a young person in front of you who's trying to decide between all these amazing PrEP options and they're not so sure, picking something that's more permanent in their body or lasts longer in their body might not be the best thing to start with. But going through all of those points with a patient is important. All right, PrEP options counseling. So we have TDF, FTC, or Truvada. We still have it. It's still available. It comes in generic form. It can be as cheap as $20 a bottle I've seen online. It's one pill once a day. It's 99% protective with sexual exposures, anal and vaginal, 78% protective in injection drug users. The side effects are nausea, vomiting, diarrhea, usually less than a week, reported by only 3 to 5% of patients. Usually we tell people to take it at night before they go to bed for the first week, so they sleep through some of the side effects. Most people feel nothing after the first week. Clinical considerations, it's extremely rare, but clinically significant, so I'm mentioning it. Decrease in kidney functioning that usually is resolved when the medication is stopped. We have prescribed PrEP in the last 10 years to over 4,000 people. And I've seen this once or twice where it hasn't been driven by gym supplements, creatine at the gym, other things that I ask them to cut back on, and then their kidney functioning goes back to normal. Counseling for patients with positive Hep B, you need to counsel folks if they are positive for Hep B. Chronic or acute Hep B infection, because this is also treatment for Hep B. So productivity starts for anal sex after 7 days, or what we recommend to patients is taking 2 pills together. After they leave clinic, that night with dinner, take 2 pills, and then the protection starts after 2 hours. And that way they can just start taking it daily the next day. Productivity for vaginal sex is between 7 to 20 days when taking daily. We also recommend the 2 pills the first day to jumpstart protection. There's a lot of new good data showing that folks who are assigned female at birth maybe do not need to be as perfect with their regimens as we once thought. It's still very protective even if folks are missing pills. Cost considerations, so it's covered by most insurances. If you live in New York, Medicaid covers it, no problem, no prior authorization. If folks need to buy it out of pocket, we've seen $20 to $30 per bottle. No free options if you are uninsured. So Gilead, the drug company that manufactures Truvada, no longer supplies this in their patient assistance program. You have to get Descovy. So if you have somebody who's uninsured, they most likely will have to start on Descovy if they can't pay for Truvada. But I feel as though like we are all getting used to that, and Descovy is something that we have been hesitant for in the past. But if it's free for patients, it's more important that we get it into patients' hands. So Descovy, TAF FTC. It's a 1 pill once a day, again, 99% protective with exposures to via anal sex. It's also shown, there's a study done as part of the lenacapavir trial showing that Descovy is as effective in folks who are assigned female at birth, which helps us with getting folks that are uninsured onto PrEP as well. The same side effects, usually less than a week, nausea, vomiting, abdominal pain. The clinical consideration I just want you to make sure you know about is on an average of a 2-pound weight increase, and and the folks involved in this clinical trial listed here. There was a 2-pound weight increase and a 2% cholesterol increase compared to folks who were on Truvada. So make sure you let patients know if they've been on Descovy for a while and they've noticed weight gain. It could be because of the Descovy. Counseling for patients for positive Hep B as well, because this is also treatment for Hep B. So productivity starts for anal sex after 7 days when taken daily. The data that from this trial, from the PROMISE trial, or PURPOSE trial, sorry, also speaks to the vaginal sex productivity. We don't have good data as when that is effective. I would assume it would be the same as if you were taking Truvada. 7 days for anal sex. You can do the 2-pill loading dose. There's no data to support that as there is with Truvada, but it's definitely 7 days with taking daily Descovy for anal sex productivity. So for folks that are insured, you might need a prior authorization if you want Descovy. It's not complicated. Most of the time you don't need it at all. The patient assistance program for uninsured folks exists, so you can get this for patients that are uninsured and make under about 75, 80K. The problem with the patient assistance program is the meds need to be mailed to the patient's home. Or it could be mailed to your clinic. You can't go to a brick and mortar pharmacy anymore. So that's the barrier for a lot of patients. Some of our patients get it delivered to our clinic. They won't send more than 30 days at a time. So that is a barrier for folks who are uninsured. Okay, on demand. All of you said you wanted to know more about it. Yay. Okay, not all of you, 55%. So on demand is usually with Truvada. That's where it's been most studied, and we have good data that it works very well. 2 pills, 2 to 24 hours before you have sex. 1 pill the next day, and 1 pill the day after that. The trial that was done in 2015 showed 86% protectivity with anal exposures. I would believe it's higher than that. There is some modeling studies to suggest that this could be effective for folks assigned female at birth. If you want to talk about that offline, we can talk about that offline. I think it's very off-label, but for folks, it is out there to have that as an option for patients who can't manage daily at all, who are assigned female at birth. Side effects: nausea, vomiting, diarrhea. Same with Truvada because you're giving Truvada. Clinical indications: if the person's Hep B positive, we do not recommend on demand because, as we said, Truvada is treatment for Hep B as well. So after the first dose, take 2 pills. After 2 hours after that, you're protected for anal sex. Subsequent doses are necessary, so if you miss the subsequent doses, you actually should start PrEP. But this is a simple regimen that you can give to somebody. 4 pills. For folks that have sex like once or twice a month, this is a great option. They don't have to take it daily. They just have to know when they're going to have sex and take the 2 pills before. So for folks, same cost coverage for Truvada as well. It's that you're buying a bottle of 30 pills. It's about $20 if you buy it just out of pocket. Otherwise, you could just write it for 30 pills and get it from your insurance. So here's New York City's graphic: 2 pills, 2 to 24 hours, 1. Here's one we built. So go on Grindr, take 2 pills, get ready to go out, have some sex, 24 hours after that, and then 48 hours after that. So if you keep having sex, which we get this question all the time, just keep taking it daily. You need to make sure to get the 2 days after the last time you had sex. So a good example would be, you're going to Fire Island for the week, you haven't been on your PrEP, you take 2 pills on the ferry, go to Fire Island for the whole week, take it daily, and then make sure to take it 2 days when you get home, 2 days after the last time you had sex. All right. Should I stop for questions? Do you guys have all the questions or no?
We do have 2 questions actually.
Okay, before I go into injectables, I think I have time. Okay.
All right, Carrie, we did have a question that came up, and it's, don't you need to maintain a therapeutic level of the PrEP med for it to be effective?
Yes, so a therapeutic level of the PrEP med would be those 2 pills, 2 to 24 hours before you have sex, gets you to a therapeutic protected level. You just need to also make sure to take the 2 pills after that to continue the protection.
Okay. The second question that came up is, what is the youngest age that PrEP therapy is approved for? do they need parental consent to start oral or injectable PrEP? I know that 13-year-olds can be tested and treated for STIs without parental consent, so does this apply to PrEP as well?
It does apply to PrEP. So in New York State, I'm sorry I can't speak to other states, but in New York State, PrEP is considered protected for minors. So they can receive it without parental consent, without any problem as far as on your end legally. There was more to that question though.
Yes. The question was really, what is the youngest age that PrEP therapy is approved for?
72 kilograms, 35 kilograms, 72 pounds. So it's weight-based. So if you think this is a good option for a younger person, they are at risk of HIV, then this is completely available to them.
All right, well, that was all the questions for now.
Awesome.
But if anybody has questions, please put them in the Q&A box and we will answer them at the end of the talk.
All right, let's move on to the injectables. So the first one we have is a long-acting injectable cabotegravir. We call it Apretude is the brand name. So that is a IM injection, it's 3 milliliters into the gluteal muscle. So if I were to start today, I would then get another injection as a loading dose in 1 month. And then after that, every 2 months, every 8 weeks. It's more effective than daily pills, but it was a non-inferiority trial. And these are folks that were in a clinical trial and receiving their injections. Additionally, people miss pills. It's hard, I mean, other than missing your injection, it's hard to miss this. So it was more effective, as you've probably seen in the commercials and patients tell me all the time. So the side effects are site injection reactions. So that's the biggest one. Patients say if the area feels sore. Sometimes patients say they have like shooting pain down their leg for a couple of days. And you know, people have the reasons people have stopped though have not been that. Most people get used to the site injection reaction. It's more just like convenience and being able to come in every 8 weeks, I would say, is the biggest reason why patients of ours have stopped. We have, I would say, over 200 patients on CAB, maybe a little less. Okay, clinical considerations. The medication tail, which I'm going to talk about in a second. There's interactions with anticonvulsants. So if you have somebody who has a seizure disorder, just make sure to double check the drug interactions and some antimicrobials specifically for TB. So there's one study that looked at the time to protection after injection. It's not great. I mean, we don't have a lot of really good data about it, but we're estimating approximately 7 days after the first injection. So usually for folks, the conversation goes something like, you're interested in PrEP, that's wonderful. It's going to take me like a week to 2 weeks to figure out the payment process. Let's start you on oral PrEP right now. And then moving forward, start you on oral PrEP, and then we'll work on getting the injectable medication. What this does for me is gives me more assurance that this person is protected while we're waiting for the CAB. And that way, I'm more confident that they are HIV negative when they come in for their CAB injection. So usually I have people who started on something else when they're transitioning. If somebody's coming in without any CAB at all in their body, or any HIV prevention medication in their body when they're coming in, I usually tell them it's about a week, and then you're protected. Cost considerations. It's expensive. It's $3,700 per injection. There is a prior authorization 80% of the time. And there is a patient assistance program, same income barrier, or same income limit. So you have to make under around 75K, and we can get it for you for free from the drug company. I've had one person declined, like straight up declined, no matter how much I appealed. And it was an employee-based plan. So it was more, there's not a ton you can do, unfortunately, but that's one out of a bunch, which I think is pretty good. But Medicaid's fine. There's less and less prior authorizations with Medicaid these days, which is great. Okay, so this is the tail I talked about. So I just got my injection. I think this is great. I'm going around, living my life. Good level of protection. I get my second injection. I get my third injection, and then I'm like, you know what? I want to travel more, and I don't want to have to be tied to a clinic every 8 weeks. I'm going to stop. So the way that CAB works is it will stay in your body up to a year after your last injection in some form. So everyone's different. Your body mass plays into this. So basically, somebody has a waning level of cabotegravir in their body up to a year after their last injection. So why is this important? You basically have a suboptimal or subtherapeutic level of an HIV of a ARV in your body. So if you were to become HIV infected, we're worried that you develop a resistant virus. So the way around this is to make sure you're doing something extra to protect yourself from HIV during this year. Is that taking PrEP, oral PrEP? Is that using condoms? Is that abstaining? Whatever it is, there just needs to be an extra layer of protection for a year after your last injection. This is very difficult to explain to patients. Usually it's for the folks that say to me, I never want pills ever, ever, ever. I want the injection. I make sure they know that if they were to stop the injection, that we need to do something extra other than just not taking anything. If you're going to have sex in the next year, we need to do something extra. So you might need to take pills. Usually that is the only population that really matters for, but I just want to make sure everyone is aware. Okay, lenacapavir, new kid on the block. It is 2 injections sub-Q into your belly or your thigh. When you take the first injection, you also take 2 pills right here. You can't tell how big they are because I didn't put something for scale in here, but they're pretty big. So 2 injections, 2 pills the first day, and then you take the next 2 pills 24 hours after the shot in the pills. So then you're done. You are protected for 6 months. It's more effective than daily pills for the same reasons CAB is. There's no missed doses. For anal and vaginal sex. Okay, the site injection reactions. The clinical trial says only 64% of participants. I have yet to see a patient that we've given Len to that does not get a nodule. So the nodule feels like a lipoma under the skin on both sides. I've seen it last up to 6 months pretty regularly. So I just make sure you're very real with your patient that they will have a bump under their skin that's palpable but not visible for 6 months. Reactions decrease over time. I'll let you know. We're just now getting up to our people who are coming in for their second injection because we started it. But they definitely last 6 months, and you can feel them. So some people are just totally fine with that. It's not a big deal. Some people, that's the reason they're stopping. So just keep that in mind. The medication tail exists for lenacapavir as well in the same way. A year after the last injection, you will still have some medication in your body. You need to do something else on top of the waning PrEP to protect yourself from HIV. Interactions with some anticonvulsants and antimicrobials. WHO put out some guidance showing interactions with erectile dysfunction drugs. Usually when I educate patients on this, I just say, this could enhance your erectile dysfunction drug. Everyone's different. Make sure to just split the pill in half, start low and go slow for the foreseeable future until you realize like how much it affects your erectile dysfunction drugs. WHO also mentioned interaction with ketamine. If you have folks who are taking ketamine, you just might want to give them a heads up about that. Protectivity starts 2 hours after the second set of pills, so pretty quick, which is great. If you don't take the pills, you have somebody who's like, I'm not taking those horse pills. No. It's actually like 3 weeks after the first injection. It's pretty long, so encourage the pills if you can. Cost consideration, these are real expensive. It's $14,000 for each injection, and the cost of the pills. Prior authorization should be expected. This is more like there's definitely prior authorizations for lenacapavir. Patient assistance program is available through Gilead, which we can get lenacapavir for free for folks that make around 75K and don't have insurance, which is always an option as well. So I put this slide up. This is from the lenacapavir trials. Again, it's everyone has a nodule. I have not seen anyone yet who does not have a nodule. So just keep it in mind. So this is our injection experience, so you guys can see what it looks like. This was our first patient to get lenacapavir. She consented, don't worry. She'd been on CAB for 2 years, 3 years, 2.5 years. And she was very excited. She travels for work. She was very excited about getting the every 6-month injection. So notice how Jen goes in here and holds the needle. This is very intentional. I'll show you why. She's going very slow. It's very viscous. She holds it in there for a while to prevent leakage. I'll show you in a sec. There's some leakage that is common and expected, but she's going slow, holding it in to kind of reduce the leakage. And this pressure is to reduce the leakage as well. You can't hear what she's saying, but she's saying, I didn't even feel it. All right. So this is the leakage. It's yellow. I've had patients say that they're oozing some yellow plasma. It's viscous. A small drop is normal, but sometimes, as you guys know, like if you're wearing a white shirt and all of a sudden it's on your white shirt, like it's noticeable and could be kind of scary to think that something's leaking out of your body. So we usually apply pressure. This is a normal amount. A lot more than that, I would tell them to come in. But this is, I also have either you or have your nurses who are doing the injection educate the patient on that this will happen as well, so they're not freaked out when they get home. So I kind of said this earlier, but for a patient who wants to start on PrEP or injectable PrEP, I usually account for 1 to 2 weeks of prior authorization, delivery, etc. So this is where I'll start somebody on an oral regimen while we're waiting. Just so I can make sure that the person is protected while we're waiting, and also that their HIV status is negative while they're waiting. So we'll do full labs when they come in. We'll work on the prior authorization, etc. I'll repeat the labs when they come in for their injection, but as you guys know, that test does not reflect a couple days before. So having the PrEP on board has been really helpful in feeling more secure about providing len, which is going to be in their body for a while. If that person had sex while we were waiting for their injection. I mentioned the drug-drug reactions. The tail is definitely something to consider as well. So bridging, each of these pills equates to 1 week of protection. So if you ask Gilead, they'll say if somebody is traveling and they need to bridge their injection doses, so they're not going to make it in, you can give them this pill, 1 pill once a week while they're waiting to come in for their next injection. I don't know how easy these pills are going to be to get. Right now they're in the packs when we order the lenacapavir, so I'm just being a Debbie Downer and thinking they're not going to be in every drugstore. So I would say my solution to bridging is to take Truvada or Descovy while you're waiting for your next injection, which is completely acceptable as well. So just consider that if somebody can't make it in for their injection. So I didn't mention this earlier, for lenacapavir, the window for injection at 6 months out is 2 weeks before and 2 weeks after. So you essentially have a month to receive your injection, give or take. They recommend if you're outside of that window at all, you should start providing some supplemental medication for HIV prevention. So this is another resource that's available, and on the Blueprint website, it goes through each type of regimen and talks about estimated costs. There's a lot of other information on the spreadsheet. It's large. Maybe not for patients, maybe for you as a guide while you're doing PrEP options counseling. All right, for Sam, what happened to Sam? All right, what happened with his PrEP options counseling? So he wanted to start today with the oral regimen, but he's interested in long-acting injectables looking like lenacapavir moving forward. So we were able to give him an oral regimen that day. And we are trying to still figure out how to get him off his parents' insurance so Gilead will pay for his lenacapavir. It's pretty tricky, but he's on prevention methods. He's getting tested. He's getting screened. And he feels better in his sex life as well. All right, that's us. So some of our strategies in our clinic to reaching patients where they're at. These are some of our strategies. So we have our sexual health coordinators as the front line to patient care. We have a dedicated warm line to answer community questions. We have extended walk-in capacity, and we really try as best we can to care for anyone regardless of insurance or ability to pay cost or sharing fees. And we use the goals approach to address sexual experiences as well. That's us. Yay. I'd love to hear any questions anyone has. Yeah.
Thank you so much, Carrie. That was
you.
fantastic. We do have some questions that have come in. The first question is, if a patient forgot to take a pill, does the patient take 2 pills the following day, even though the person did not have sex?
If the person forgot to take their Truvada, they did not have sex, they can just take it then as normal, like start their medication the same way. If they want to be sure, they could take 2 pills the next day to make sure that they're covered for their next sexual experience. But we usually say 1 day, it's okay. 2 days, fine as well. 3 days and you have sex, you really need PrEP instead. So most of the clinical trials are saying 4 doses a week, you are protected still of Truvada. So I'm pretty confident in the 4 doses a week. Anything less than that in sexual activity, I would recommend PrEP.
Okay, great. Thank you.
Yes.
Second question that came up is, are the injectables only able to be administered in the doctor's office, or do patients ever take them home?
They are only recommended in the doctor's office. I don't know if they're only recommended in the doctor's office. I would say the gluteal injection for the cabotegravir is large. Like, I would not mess around with that on your own. I could see, while there's no evidence and this has not been looked at yet, I could see a world in which, just like GLP-1s, somebody is giving themselves a lenacapavir injection. We're not there yet. So I would move away from that if someone is asking. I think the next thing that's going to come is lenacapavir in the arm, which I think will be different for patients. The nodules are a big thing. It's a big deterrent. So anywhere you can put those nodules other than somebody's belly they've been working really hard on at the gym, I think is a better thing.
Okay, thank you. How are your patients reacting to injectable PrEP options versus oral options?
I think a lot of people see the ads. While they love coming in to see us, they don't love the process of coming to a clinic. I think the excitement around lenacapavir and coming in every 6 months, I think the nodules are the biggest deterrent. I think people are still really excited about that concept, but I think if we can move away from having it be something that causes the nodules. I think for cabotegravir, because people have to come in every 2 months, so they're coming in more frequently then, it's all about the pill burden for most folks. They are just excited about not having to remember to take a pill, and they feel really protected that way, which is great. It is more labor intensive on them to come in every 2 months though.
Great, thank you.
Mm-hmm.
Do you ice the site for injection before and after the shot?
Yes. So, we give the patient the option. For the first time I do, just because I don't want them to get worried. I put an ice pack. So we just did our first thigh injection the other day. That's why I touched my thigh. Ice pack on there for like 2 to 5 minutes before the injection, and then just put it back on when they were done. yeah, I think it's a really good idea. Some patients are used to it now and they don't need it or want it. Definitely for Len, less so for Cab. I feel like it's so deep that the burning going in is less, but yeah.
Okay. Where can we find the educational resources to post in the clinic?
HIV, could someone put that in the chat? HIV blueprint?
We can add that to the chat.
I'll add it to the chat. So you go to, there's a PrEP resources, and we have a great injectable flyer that's double-sided that you're welcome to put. We have it all over our clinic, which is also great if you don't, I know all of you are very busy providers. We just hand it to patients. Oh, you're interested in an injectable, you're not sure. Here's some information to look at while you're, going through clinic or when you get home, and let me know if you're interested. It's been great. And that also has the PrEP options counseling flyer and also the huge chart that goes through all the options.
All right. How do you suggest counseling a patient who inconsistently takes oral PrEP and is not taking it on demand?
Yeah. So we have a lot of patients like this. I feel like every time I see them, or they come in and they say they need PrEP because they missed their doses. Like, have we thought about injectable? Like, is that something that would work for you? Like, we have this option. Like, you don't love coming in for PrEP all the time, so like, let's try to make this less of a tragedy every time you miss your PrEP and you have to take PrEP. I have a lot of solace in knowing how protective Truvada is, even if you miss a couple doses. But yeah, this is not a great place to be. I think the injectable options for those folks moving forward is the way to go. And a lot of people have switched just because they admit to themselves they're really bad at taking their PrEP. But we also, like, whenever this happens, I make sure they have the PEP hotline number, they have our number. So if they do miss and they have sex, they know what to do about that and not just ignore it. So give them an option, definitely, like a definitive option. This is what you call when you haven't taken your PrEP for 2 or 3 days and you had sex.
Okay. I think there's one more question. I missed what was said about weekly Yetsugo pills.
Yeah.
Can you explain that again, please?
So when you're getting the injection, it comes with a bottle of 4 lenacapavir pills that are 600 milligrams. If you ask the drug company, or if you go to a Gilead talk, they'll say that is the medication you should use for bridging when you miss a dose of lenacapavir, when you miss your injection. I just don't know how common it's going to be in pharmacies to be able to get that medication. It's already hard enough to get some other drugs because it's so expensive. So while if you have access to those pills, it's 1 pill once a week while you're bridging. If you can't find that, which I'm assuming is going to be more of the norm, then I recommend to patients to take Truvada or Descovy while they're bridging, which is also, as you know, protective.
Okay. All right. Thank you.
Yeah.
We don't have any additional questions right now.
Cool.
So thank you, Carrie.
Thanks,
Very
guys.
much appreciate your presentation. We are going to take a break now until 11:10. So we'll come back at 11:10 with our final speaker. It will be Dr. Jacob McLean, who will be presenting on STIs 102.
Hey.
Thank you.